All right. So I will start. I am Ira Kirschenbaum. I am the editor of the Journal for Orthopedic Experience and Innovation, otherwise as known as Joey the Journal. We have a great article tonight to discuss, as well as a great topic. We have the authors here tonight as well, which are particularly good to have, as well as a couple of other key opinion leaders. I'd like to introduce Simone Brown, who is one of the authors of the article. Simone, why don't you introduce yourself? Tell us what you're doing. Tell us where you did this research, and also when you finish with that, tell us how this idea came about.
Sure. So my name is Simone Brown. I was born and raised in Paramount, California. I attended my or received my bachelor's of science degree in exercise science from Texas A&M University Commerce. Also received my MBA and MS in management from the same institution. I acquired a master's in public health from Tulane University. And I'm currently starting a second year of medical school at Kansas College of Osteopathic Medicine. So I worked as a research assistant with Dr. Mary Mulcahy for about 2 years, which is where this project was formulated. So I started, or yeah, so this came about typically as the brainchild of Dr. Mulcahy. She's very interested and very passionate about women's sports medicine and injuries in high school and female athletes. So this was her conception and a very great project, and I just wrote along.
I think you might have done a little more than that. Hello, Mary. How are you?
Great. Thank you so much. Sorry for being a few minutes late.
No, no. So we're recording this. We're gonna put it on the website. I had a little bit of a glitch on the Zoom invitation stuff. Normally 3,000 more people get invited, and I messed up. So sorry for the slightly lower attendance, but we're gonna put this on our journals on our Joey recorded site. And it's going to get probably 200 or 300 views. It's going to be great.
Sure. No, whatever's best. Yeah. Yeah. Happy to be here.
So where did the idea for this come from? I mean, it's seems such a selective thing, in a lot of ways, such an important finding. So it's not like we go walking around thinking about this every day, and then all of a sudden you think about it and you find an important finding. So, what was the brainchild behind this?
Yeah. I mean, I think really the idea is that we're seeing more and more like athletes at a young age feeling like they have to choose one sport and like only participating in that sport. So whether it's volleyball or soccer or basketball, and they're playing year round. And I was in New Orleans for the past 6 years, and now I'm in Chicago at Loyola. But certainly in a warm weather place like Chicago, like New Orleans, Chicago's warm right now, but it's not warm in the winter. Um,
And it wasn't a
but in the South, I mean, it's warm all the time. So like the outdoor sports you can play all the time. So soccer and whatnot. And so they're playing year round. But I think even in other parts of the country where for, sports that are traditionally played outdoor, they'll play indoor in the cold weather months. So there's just that's really where the idea came from, is just seeing more and more young athletes feeling like they have to choose one sport over all others at an early age in order to be very good at that
yeah.
sport. But I think we've seen some incredibly successful, very high level professional athletes who have played lots of sports and are obviously at the top of their game in their professional sport. So we realize that there's value to having diversification in the sports that you participate in too. Um, but yeah, it was just kind of seeing those patients in clinic and realizing that the young athletes think they have to choose.
So, were you surprised about the injury patterns that you found in the study?
Yeah, I mean, so we saw here that focusing on a single sport was not associated with higher rates of injuries. Um, and I don't know, I mean, you think if you're doing the same sport all the time, you're going to have the same type of demands placed on the body. So I think I would have expected to see a higher rate of, I guess, specific injuries that are related to that sport. Simone played basketball in college. So, jumping related injuries, like you would expect to see more like knee related issues in those athletes playing basketball year round versus an athlete who's playing, basketball and soccer or volleyball. So I was a little bit surprised by that, admittedly.
I was thinking about Malcolm Gladwell's book Outliers, where he talks about someone who needs to be an expert at something, whether it's the Beatles or a lawyer or an athlete, needing to put in 10,000 hours, 10,000 hours to be an expert. So sometimes I was thinking when I was reading the article that maybe these athletes are getting so good at the nuances of the movement in the sport versus changing to something else and having to use a different set of muscles, um, that I would think cross training in a sense would put you at risk at the beginning of each time you train.
It might. I think that's a very good sort of thought process. And you're probably right because I mean, there are different skills for the different sports. Certainly, if you're playing basketball versus soccer or whatnot. So that's a very good theory. I mean, I played soccer and I ran track, so I had some that the diversity. But and I don't know, Simone, maybe you can speak to your personal experience too. I'm not sure if you played any other sports besides basketball or if you were playing basketball year round, but how you think that impacted you or your teammates too.
Of course. So growing up, I played soccer and basketball, but once I got to maybe fifth grade, I specialized in basketball. So I was playing basketball year round at my school and on an AAU travel team. So basically every other day I had basketball practice. And this was consecutive from fifth grade up until maybe my senior year of college. So it's quite a lengthy amount of time. And I've had three knee surgeries, and I had to medically retire from basketball because the doctor told me if you play one more year, there's a higher chance that you'll need a knee replacement by the time you're 35. So I said, okay, well, I would like to keep my youthful knees as youthful as possible. So I retired. I still have knee problems here and there with arthritis, but I think specializing in one sport with the constant demand, the jumping, and the running, sprinting, all these different exercises that focus on making sure that we're better basketball players, definitely hindered my athletic ability. But I think the other part of that is if I'm receiving proper training from the strength and conditioning staff and load management from the coach. Because in reality, we really didn't have that at the university that I played basketball at. So it was more of, okay, are you producing points wise? Then you're going to play the most amount of points, and not really looking at, okay, you played 25 minutes this day, 35 minutes this next game, which was typically a day apart, without really, there wasn't a lot of thought process into, okay, how are we really utilizing these players and what can we do to make sure they have a longer career as opposed to how much can they produce for me in this season.
Great. I'm going to flip to the idea of athletic injuries in female athletes specifically, which I think is a well-known topic, but still not researched probably enough and is constantly changing. Mary, where did the idea with this was looking at female athletes in this particular article. Do you think you'd get the same results in male athletes? And then I want to flip to just a general discussion about sports injuries in female athletes and where that stands right now.
That's a good question. I mean, I don't know the answer definitively, but certainly we know just overall there are huge differences in the risk of specific injuries in male versus female athletes. But it would be interesting to look at, male athletes who specialize versus those that don't. I haven't seen any related studies, so I don't think I can really speak to that. I haven't seen anything related to that, honestly, other than just the general concept of specializing versus not, but not looking specifically at injuries related to specializing. Um, and then with regards to injuries in male versus female athletes, there are certainly injuries that female athletes are at much higher risk of sustaining or are unique to female athletes. I think we're all well aware that ACL tears are among the most important, most discussed, most researched with female athletes being upwards of 8 times, at upwards of 8 times higher risk of sustaining an ACL tear compared to male counterparts for many reasons, both sort of non-modifiable and modifiable risk factors. And fortunately, there's a ton of research and a lot of programs that are developed to try to decrease the risk of injury. So those injury prevention programs focus on addressing the modifiable risk factors and have been shown to be very effective. And so we're seeing that there's tons of literature, of course, with regards specifically to ACL, and then some literature with regards to some other injuries, but definitely the majority of it focuses on ACL tears. So I don't know. What other specific things did you want to dive into with regards to that, Ira?
Yeah, I was thinking that first of all, I was wondering whether or not female athletic programs had the same trainers and the same type of money that went into some of the male college programs, Title IX included, but it may not exactly be the same, the level of preparation and training in that.
No, it's not the same at all.
Yeah.
I think we saw that. When was that most recently with like the Final Four or whatnot, with like the resources that the men's Final Four teams or Sweet 16 or whatever it was in the NCAA tournament. I think that was the most recent example, right? Within the past couple of years. And Simone, maybe you would know because I know you're following that to the T. But it was very like publicly acknowledged that there was a huge discrepancy in the resources that the female elite level athletes had access to compared to their male counterparts. And some things have been done to address that, but I think just in general, if you look at like Division I female athletes versus Division I male athletes, or even at each of the levels, like the resources are not the same. The athletic trainers, the weightlifting, facility, having a performance coach, like all of that, like in general is quite different for male and female athletes. And I think that definitely could impact the risk of injury, in addition to things that we already know are risk factors. So yeah, that's a really important consideration. But I've never seen certainly anything in the literature specifically looking at that. And maybe you're giving us some new ideas for projects, Ira. I appreciate that.
Yeah,
Simone, make note. I think there's a way to investigate that because I haven't seen anything written about it.
Simone, what was your experience in college when you compared yourself to the men's basketball team?
I noticed that our conditioning was a lot different. In my head, I felt like our conditioning was more strenuous in the men's team. We were required for the women's team, we had to run a mile in 8 minutes. The men's team had 15 minutes to run a mile. And I was like, okay, that's kind of interesting. But before we even ran our mile, we had to do at least 5 sets of running up and down the bleachers, other plyometric exercises like jumping over hurdles, bear crawls on the turf. And this is all before running the mile. And the mile determined if we got our basketball jersey to actually be a part of the team. And this is in college on a scholarship. So I thought that was pretty interesting, just to see the men's team just kicking back, jogging, doing a little conditioning. Meanwhile, we're working our butts off in the Texas heat at that, trying to make such high demands that were set for us. But to kind of echo what Dr. Mulcahy was saying, there are some stark differences for like the WNBA and the NBA specifically. I know the WNBA, it's illegal for their teams to charter planes after games. They have to fly commercial. So you have these 6'2", 6'3", 6'4" athletes or women sitting on these commercial flights with other, common citizens like me. Whereas the men's professional teams, they get to fly private jets, get to their destination. Let's say they're traveling to New York. They get there 2 to 3 days before the game, so they have time to recover from their previous game. Whereas the women's team, they may have layovers, so they're stuck. They can't rehab properly because they have to catch this flight. There's no leg room. They can't stretch. So I think it's really interesting to see how women and men's athletes are treated differently. And I don't know why there is such a huge discrepancy, but I think that is something we should look into.
Yeah, I except in tennis, whether if you're Serena Williams, but certainly WNBA and the NBA. I have a question that kind of came to mind with thinking that, and I am a joint surgeon. As I like to say, I identify as a joint surgeon. Um, and but I will say I read a lot of literature. If females have higher rates of ACLs, do females have higher rates of re-tears of ACLs? And I always wondered that.
No. So the rate of re-tear is actually quite similar between male and female athletes, but the risk of just an initial ACL tear is higher in female athletes. And there's some good literature discussing this, especially like out of the Mars group and the sort of multi-center studies supporting that. So I guess
Have they come up
the
with
quick answer
reasons
is no.
why?
I
Because
mean, I don't know. I think
sorry,
there are a lot of factors affecting re-tear, but patient sex is actually not one of the main reasons. So, I mean, it can be like, the most common reason for failure of ACL, after ACL reconstruction is technical error. So, and among that is like placement of the femoral tunnel. Tibial tunnel is also there. It could be both tunnels. There are biological reasons contributing to failure. There could be, tibial slope contributing, but patient sex is not up there as to a main risk factor.
so what that says to me is that it's very possible there is something genetically in the evolution of the substance of the actual ACL fibers rather than because the same modifiable factors could be present in the re-tear situation. Does that make sense? And so what has changed from when the person got the tear to the person got the reconstruction, and maybe it's just a stronger ACL component.
Yeah, I don't know. I mean, certainly like the modifiable. Gosh, I'm sorry. I'm in my house. That's why lights are on and off, and you
Yeah.
can hear noise. Um, but anyway, yeah, those modifiable factors are there. But I think the big thing is that after having already undergone ACL reconstruction, it introduces all the surgical factors too, right? And with the absolutely the highest, like the most significant risk factor contributing to re-tear are technical errors. And so that is equivalent between that's an equivalently contributing risk factor for male and female athletes. So yes, and there, I mean, I actually gave a whole talk about this at ISAKAS in June. So it's interesting to sort of dig into that topic. I mean, even things like related to, hip pain and femoroacetabular impingement can
Yep.
contribute as a risk factor. So
Really?
there are many, many things that contribute, but technical errors is far and away the most significant contributing factor.
Right. So how do we go about solving solving some of this epidemic of injury in female athletes? I mean, because by all accounts, it's an epidemic by proportion, right? I mean, if you had eightfold incidence of COVID in one group versus another, it would raise your eyebrows quite significantly about that. So what are some of the efforts about that right now?
Yeah, it's a great question. I mean, I think the first and most important point is raising awareness, which I think is happening, right? So that we're having this discussion right here. We're talking about it at the big national sports medicine meetings, right? This is a topic of great importance. We're seeing these type of articles published extensively in all of our orthopedic journals. And so there's huge amount of recognition, and that's a big change just in the past 10 years, right? Huge change. Looking specifically at injuries in female athletes, differences in outcomes, differences in treatment options. And so I think the first is being aware that there are differences, that we may need to treat our male and female athletes differently, and that we need to look at the outcomes of our male and female patients and athletes separately, right? I think
Right.
for any of you who are reviewing articles, Ira, I know you review like So one of the critical things that I look at when I'm looking at articles and reviewing them is, did the authors break down the data and the analysis based on patient sex? And I think, 95% of the time, they're going to say like, oh yeah, there's 150 patients, like 100 were, male and 50 female. And then they just
Oh, you're on mute.
yeah, sorry. I accidentally hit that. I was like speaking with my hands. That's what happens. Um, so they may provide a breakdown of the number of patients, but they actually then don't break down the result. They don't analyze the results separately. The results are analyzed together. And so I always make a comment like, please provide male female breakdown and provide, like, discuss the results separately. That's how we're going to really be digging into these topics, and get more information about the impact of patient sex on injuries and outcomes, and how it impacts our treatment options.
It reminds me very much of a lot of the work by Vin Dasa at LSU in joint replacement, where he talks about how much of the literature does not talk about social determinants of health in articles, race, language, health literacy. And he wrote an article for Joey, the initial article, and then another article in a lesser journal, the Journal of Bone and Joint Surgery. But it's who's counting, but he wrote the larger article there, but the initial pilot study was done in Joe, and it was showing how less than 5% of the literature looked at race, social determinants of health, income, and health literacy. And in fact, he got a paper rejected from one of the journals, I think it was Clinical Orthopedics, because they said, talking about this issue, he says these issues shouldn't be in research. One of the reviewers said, that they're not relevant to the anatomy of the hip and the knee or something. And it's actually mind-boggling, that's a block, and you're seeing that in the same in sports literature as well, right?
Yeah, I mean, I do think there have been at least a handful of articles looking, focused specifically on social determinants of health in the past couple of years. And actually, like, I'm working with some of the members of our team on a paper related to that, actually, with regards to shoulder instability and management of shoulder instability. But I think it's a very good point, very, very good point. And Simone, I actually would throw this to you too, because you're very in tune with this. I don't know what you've seen in the literature, how you feel impacted personally, or just, being in medical school now and sort of paying attention to these things. Like, what's your take on that?
In terms of like diversity and how it's like brought about in research.
Yeah, and social determinants of health and how it's investigated in the literature.
Awesome. Yeah. So I think it's heavily understudied, and not really incorporated as much as it should be into the medical school curriculum. For example, I know this is sports medicine, but our most recent block that we did was dermatology. And out of 600 slides that we had of information over 2 weeks, and the multitude of pictures, I think we had maybe 350 pictures. Only 4 of them were of brown or black skin. So that was something that I brought up to the school and be like, hey, I know, this is dermatology. We're trying to make sure we get the foundational knowledge that we need to know for our board exams. But you can't really prepare a class of, culturally conscious students without exposing them to all of these different skin types. And I did a quick little thing with my classmates. I showed a picture of Lyme disease. So it showed the first one on, a black baby, and then showed the second picture was on a white baby. And immediately they knew it was Lyme disease on the white baby. But when the black baby showed up, they were like, we don't know. Is it like child abuse? Did they get electrocuted? Like, what is it? And I'm like, if the first one is Lyme disease, what is this one? They said, oh my God, is that Lyme disease as well? I said, yes. So the lack of exposure, I think, is a real big factor that we need to work on in medical schools. And, once we get that foundational knowledge in medical school, then you'll have these culturally competent physicians in the future who are able to, when they get to the research part, be like, hey, we need to make sure we're more cognizant of, social determinants of health, socioeconomic status, and how these, different factors play into the care that we provide these patients and how it could play out in their health outcomes.
Those are great points. I want to show something on my screen. I'm going to share part of my screen. These are a number of articles that Mary has published in Joey. It kind of creeps up on you, the volume, doesn't it? And we're very, very happy. We actually have multiple bodyguards protect Mary's life at all times when she travels, so we can keep our
Right.
numbers up in Joey as much as possible. But look at this, the factors influencing decisions to pursue multiple fellowships. The majority of orthopedic residency faculty in the United States are allopathic males. Demographics of orthopedic surgery residents. I mean, it just goes on, burnout during COVID, which we had a journal club on, which was great. And, a lot of this research, we support it, Joey, tremendously, because it's hard to find a place sometimes that, this is the edge of innovation and experience. And just because it's not the experience at the Mayo Clinic, and I'm not bashing on the Mayo Clinic too much, but when I work in the South Bronx, which is about as diverse a community as you can get in the world. And when we listen and we see articles from Mayo Clinic, from Rothman, from special surgery, the first thing I say is, that's not my community. And the insurance companies read those articles and they make decisions on, whether or not to cover people or to cover certain diseases or certain secondary complications based on those articles. And I think it's very problematic, especially, and then we look at gender differences, and we're not even scratching the surface, because within the female group and the male group, there are going to be subdivisions, of quite a bit. And we're going to learn a lot about the physiology of the body through this research, and not through who happens to go through the door because they could pay out of network. So I think that's a big thing. What's next on the horizon for your lab, Mary? What kind of stuff you guys working on? And then when is Simone going to join you in practice? Those are the next two questions.
I know, right? Just a few years away.
Yeah.
Well, she's got 3 more years of medical school, 5 years of residency, but it's not that far away. No, I don't know. Because I missed the first few minutes. But I don't know if Simone gave you a little bit of background. But yeah, we had the pleasure of working together for 2 years, and we've known each other for now many years, but worked very closely for 2 years doing research. And so it's been my absolute pleasure working with Simone, and I'm very excited and so happy that she's in medical school, finished her first year, just crushing it, and she's just doing great. And so for any of you guys that are on social media, she gives great updates. So definitely check her out. And I mean, what are we working on? Like, I have sort of two sort of huge broad areas of interest. One is, education related research, which encompasses a lot of the articles that you just kind of shared. And then, of course, many, many things related to sports medicine. And oftentimes there's an overlap there too, if we're talking about, applying for sports fellowship or diversity within sports fellowship. We have some of those type of studies ongoing. Some of the other education things, we're starting up some studies looking at away rotations, which actually I feel like there's been kind of a gap in that type of research for the past 6 or 7 years, not a lot published specifically on that topic. And then the other kind of broad area, yes, it's like lots of things related to sports medicine. So I mentioned that social determinants of health. I'm very excited to pursue that. And that was actually a couple of medical students approaching me about pursuing that type of topic. So those are some of the things just off the top of my head, but we always have way more questions than we do answers. And I think even, a discussion like this, I mean, I probably have thought of 3 more projects. So Simone, like, we'll be in touch. We share a lot of interests. And so we're already working on one other project, but I think this has stimulated a lot of other ideas. I see Gloria and others on the call. Like I'm very fortunate to work with a great team and with residents and students and my other colleagues kind of around the country. Which is really what makes for such great research.
It's great. It's great. By the way, I copyright every idea before I mention it. It's a little known fact. It's legal Zoom is very inexpensive.
Right.
Yeah. What are
No,
some of
but
the
anyway, I
things?
appreciate a lot of ideas come out of a great discussion like this.
Yeah, no, absolutely. What I'd like to do, I'd like to sort of wrap up a little bit with if anyone has any questions from the audience. I'm not going to put anyone on the spot, even though I know a lot of the people. If there's any questions, you could.
Ira, it's Paul Sethi.
Paul
Hi, Mary.
Sethi.
Hi, Paul.
Mary, thank you for yet another amazing contribution. Can you walk me through your algorithm on graft choice and the decision for lateral augmentation or LET in the 16-year-old female athlete?
Great question. This is certainly something that we discuss extensively at our sports medicine meetings. There's no right or wrong, but for me personally, so that's the, young, yeah, obviously the highest risk age group and demographic. My very strong preference for autograft at this point in my career is quad autograft. I love it. I actually, for the first few years of my practice, did a mostly hamstring autograft, and I think for all of us as sports medicine surgeons, I see Dr. Kevin Plancher just popped on there too. Many of us are influenced heavily by how we are trained. So we did a lot of hamstring autografts in my fellowship. So my first few years, I was doing predominantly hamstring autograft when autograft felt like autograft was the most indicated. Now, I mean, in the past, well, probably 5 to 6 years, I have been doing mostly quad autograft. We have seen this all for anyone who's reading the sports medicine literature. You see this written about extensively. Like there's fantastic data supporting the efficacy of quad autograft, and really, like, I mean, there's good studies showing obviously BTB hamstring. You can get great outcomes with any of these grafts, but I personally love quad autograft. So in general, algorithm for a 16-year-old, I am absolutely using an autograft. There's no question about that. I mean, if the patient and the family was like demanding, saying they do not want an autograft and they like absolutely want allograft, I mean, my heart would be broken. I would not refuse to do the surgery, but I would just try to very strongly sway them towards autograft and explain the significant benefits. But so just say in general, autograft 100% in that age group. For me currently in my practice, I'm not doing LETs so sorry for those non-sports medicine surgeons, that's lateral extra-articular tenodesis. This is an augmentation to ACL reconstruction. And one of the most common ways to do a lateral extra-articular tenodesis is using kind of the central third of the IT band. And it just provides additional stabilization on the lateral side of the knee and augments the ACL reconstruction. So in my practice, the most common indication for me for an LAT is in a revision procedure. I have not as of yet adopted it in a primary setting, although I think it's a lot of great discussion at ANA, at AOSSM, at ISAKOS. Like we are seeing this at our sports meetings, talking about some potential indications in the primary setting, which may be this young female athlete, hyperlax. So that is a patient to consider doing LAT in a primary setting. I think an absolute indication for LAT in a primary setting is if you are using hamstring autograft. And we have seen that by the stability trial, which was led by Al Getgood and others. And that data was absolutely fantastic. And so I think there's really no question that if you're going to do hamstring autograft, you should be augmenting with an LAT in a primary setting. But for me now, with quad autograft being my main go-to graft, I'm not doing LAT in a primary setting, but I would do it in a revision setting. And I'd love to hear, what you're doing too.
Well, I was actually more curious about you, but I think that's an awesome answer. I have moved away from hamstrings just because I think they're unpredictable in size in these small female athletes. I'm a curl and Joe person, so I do a lot of patella tendon, but I also do a lot of quad autografts. I do, however, slightly different in that I do a primary ALL in these girls because they're my highest risk. And it's a big lacrosse soccer population in Connecticut, at least. So I do and I add it in. And maybe perhaps I'm going to over-constrain them, but I don't want to get them into a revision operation or a secondary lateral meniscal tear that will change the trajectory of their whole life. And we'll see. I mean, we need time.
Yeah, no, I think that it's a great point of discussion, and there's the Stability 2 trial ongoing. I'm sure Kevin and Paul, I'm sure you guys are aware of that. But like, yeah, that's looking at, LET in addition to quad or BT, quad and BTB. And so that data will, I think, be incredibly helpful for us as we move forward with our, practices. That data, I'm sure, is going to be coming out in the next couple of years.
Yeah. Any other questions from the audience? We got anything there? Okay, good. Why don't we sum up a little bit? Simone, why don't you say a few words about um your research and where what kind of residency you're going to be going for, what kind of fellowship after that, and and what it would be like to join Dr. Mulcahy or Dr. Sethi or Dr. Plancher in practice, because I don't think we'll be able to recruit you to the Bronx. You got we don't our sports are different. We just have the Yankees.
But you guys have the Knicks too, so
Yeah, we do
there's
have the Knicks. Yes, yeah, that's
basketball.
Manhattan. That's Manhattan, man. The Yankees are in the Bronx. Yeah.
That's fair. So essentially, I'm still working on a couple of research projects. One that we just started with Dr. Mulcahy a few months ago. A couple of classmates and I are looking at the rate of injury and return to play in Major League Soccer players. So that's in the beginning stages of that. Let's see what else. I'm also looking to start a project looking at signaling for orthopedic programs in terms of residency and the ERAS application. Because I spent my time in June as a student working with the Walter Reed Hospital as part of the Rankin Scholarship Program. So I shadowed a bunch of orthopedic surgeons and spoke with program directors, and a lot of them are saying signaling is the way to go if you want to show interest in our program. So we're trying to, or I would hope to look at, how much of an impact is signaling and other factors of, the overall application. How does that play a role into how program directors seek applicants for either away rotations or for residency interviews? So that's my research focus as of now. I would love to join any one of you in the future as a practicing orthopedic surgeon. I've known Dr. Mulcahy since 2017, so it's been quite a while, and her mentorship has really meant a lot to me, and I've learned so much. Even though I worked with her for only 2 years, but the amount of knowledge that I've gained is insurmountable. So I'm forever grateful for you, Dr. Mulcahy, for all of the exposure that you have given me and will continue to give me. So I appreciate you.
That's great. That's great stuff.
Pleasure.
I'm gonna push a little bit. Define signaling for me.
Yes. So on the ERAS application, I just started signaling, I think, for orthopedic programs, I think maybe last year's application. So signaling is where you get 30 signals. So you get to identify 30 schools and say, hey, I'm really interested in your program. Please seriously look at my application. So that's essentially what a signal is.
Okay. All right. That's interesting. So this way you may not be able to do an away rotation, but you are saying you're high on my list.
Correct.
Yeah, that's interesting. And Mary, some final comments about some of the research and just whatever you'd like to talk about to say to our readership.
Yeah, I mean, I guess first, thank you so much for the opportunity to discuss this article and some of the related topics. It's been a great discussion. We really appreciate that. And just the opportunity to just kind of continue to raise awareness about these important issues. And hopefully this stimulates ideas for all of you guys on the call too, because the more research that's going into, injuries happening in female athletes and outcomes and treatment options, the better. And just that I will continue to be pursuing these things. Like I said before, I have way more questions than I do answers. And so being involved and so engaged in the orthopedic sports medicine community, and Paul's on here and participating in Shoulder 360 and learning a ton from the shoulder world was tremendous. And so it's all of this interaction that continues to stimulate and motivate me to investigate these things that I just don't feel like I don't have an answer to. And we have a great team. So we're just going to continue to kind of pursue these things. But obviously, I have a huge passion for injuries in female athletes, for women's sports medicine in general, and for orthopedic related education. So there will be many, many, many more related things to come. So definitely stay tuned, and hopefully we'll be back on here at some point to discuss another article.
It'll be great. I want to say thank you for everyone who's been on tonight. Dr. Plancher, Dr. Sethi, Simone, Mary, a few other call outs, Gloria, and anyone who's been here. Nicolette, who is not her first time on here. I always like to call out some students. But I want to say that this has been a great topic. The journal has been blessed to have had a huge number of articles on topics like this, not only from Mary, but from Vindasa and a variety of other people. And we'd like to pride ourselves on pushing the envelope on these types of topics and bringing them to the forefront, and showing them to our large readership. So I want to thank everybody for coming, and I'll say good night now. Okay.